am Professor Patrick.
Professor?
Dr. Professor Patrick.
Welcome back. We're going to be moving on to the endocrinologies and hemonc section. So the learning objectives right now will be to evaluate pituitary endocrinological pathways and pathologies, to summarize the common diseases of the thyroid gland, outline the management and diagnostic steps of adrenal gland pathologies, and demonstrate the complications and prevention of diabetic disease. So we're going to start out with the pituitary gland. So we've got a 36-year-old woman who presents for headaches, white breast discharge. Well, she's not had her period in 4 months. On exam, she's found to have bitemporal hemianopsia, which she's unable to see sort of the periphery of her right and left vision fields. So the diagnosis would be a pituitary adenoma. The next best step for pituitary adenomas are brain MRIs. Adenomas can be non-functioning, and they present oftentimes with mass effect with the bitemporal hemianopsia and then increasing nausea and headaches. Or they can be functioning, where they can produce prolactin, as here we've got breast discharge. They can secrete growth hormone, ACTH, or thyroid hormone secretion. So you want to treat them with a transsphenoidal surgery or octreotide and bromocriptine. Next up, we've got a 45-year-old man who presents with headaches. Over the past year, his face appears more coarse with a large jaw. On exam, he's hypertensive with a displaced PMI. So this is going to be acromegaly. It's a pituitary adenoma that secretes growth hormone. You can screen for this with an IGF-1, and then you can confirm using an oral glucose suppression test. With an oral load of glucose, you should suppress growth hormone. Confirmation is with brain MRI, and you want to treat this again with transsphenoidal surgery or octreotide. Lastly, we've got a 23-year-old man who presents for follow-up after a collision at a four-way stop sign. The patient is still in disbelief, saying, "I swear I never saw them coming." On exam, he's found to have papilledema and bitemporal hemianopsia. MRI shows a calcification of the suprasellar region, and the diagnosis here would be a craniopharyngioma. So this is remnants of the Rathke pouch, and they can calcify and form sort of like oil plaques and grow and cause a mass effect. You want to treat these with surgical resection, and pathologies will often show cystic structures with cholesterol crystals in them. Next up, we've got hyperthyroidism. So classically, we'll have a 34-year-old Caucasian woman presenting with increased diarrhea, tachycardia, and heat intolerance. She has a history of anxiety and family history of vitiligo, so some autoimmune history. And on exam, she has a prominent glare or proptosis, and enlarged thyroid with a brewy and brisk reflexes. So her birth control or birth test is negative here. So the next best step would be TSH to look at abnormally low and radioactive iodine scans to differentiate the causes. So if it's a diffuse uptake, it's more sensitive for Graves' disease. If there's nodular uptake, it's a toxic goiter. And if there is absent uptake, it could be surreptitious levothyroxine use, or if she was pregnant in this case, it could be part of the fetus excreting thyroid hormone. The treatment is going to be methimazole or PTU, and you can use a non-selective beta blocker during sort of a crisis situation, a thyroid storm, and then radioactive iodine ablation or surgical resection are going to be definitive treatments. So the same patient's involved in a motor vehicle collision and admitted to an outside hospital. She becomes very hypertensive, febrile, tachycardic, disoriented, and she's got psychosis following surgery. So the diagnosis here would be thyroid storm. So during periods of stress, like motor vehicle accidents, surgeries, injuries, the thyroid hormone can become even more active. And at this point, you would want to treat with beta blockers and steroids to stabilize the patient, and then long-term with PTU and iodine to inhibit the thyroid hormone's release. So now we've got a 39-year-old who presents for fatigue. She's had difficulty getting out of bed in the morning due to the cold, as well as constipation, weakness, and menageria. Her mother bothers her that she's gained 10 pounds. On exam, she has some dry skin, coarse hair, and non-pitting edema of the lower extremities. The next best step here is TSH evaluation. So we want to look for antimicrosomal antibodies in Hashimoto's disease, or another cause would be iatrogenic after a thyroidectomy for hyperthyroidism. Some of the complications of Hashimoto's thyroiditis would be associations with thyroid B cell lymphomas, and the treatment here is going to supplement levothyroxine or T4 hormone. Now we've got a 45-year-old man who presents following a flu-like illness with tachycardia and sweating. On exam, he's got a painful thyroid gland. So the painful thyroid gland is going to be pathognomonic for subacute granulomatosis thyroiditis, versus painless thyroid gland is in subacute lymphocytic thyroiditis. So both of these are going to be associated with viruses, and there'll be a small period of hyperthyroidism when the gland is sort of being injured and being overactive, and then it progresses into a hypothyroid state following that. So lastly, we've got a 62-year-old homeless man with a long-standing history of hypothyroidism. He's found on a park bench lethargic with profound hypothermia and respiratory depression. So this can be myxedema coma. It's a feared complication of hypothyroidism if they're unable to supplement with the thyroid hormone. And treatments, you want to do IV levothyroxine and steroids in case there's a concomitant Addison's disease, and then supportive care. So now moving into thyroid nodules and cancers. So now we've got a 57-year-old man who presents for a neck mass. There's a firm 2-centimeter nodule, and he has no history of radiation exposure or family history of MEN, both of which are very high-risk situations for thyroid cancer. The next best step with a nodule is ultrasound and FNA. FNA findings will guide the management with either observation, surgery, or radioactive uptake scan. So if there's a cold nodule, those are more likely to be malignant. The types of thyroid cancers to look for and some of the risks are going to be radiation, MEN, or Cowden syndrome. So papillary thyroid is the most common. It's associated with radiation, and it is the least aggressive, and it mets to the cervical lymph nodes commonly. The next is going to be follicular cancer. It's classic Hurther cells, and this spreads hematogenously to bone, brain, lung, and liver. This one's very dangerous. And then there's medullary thyroid cancer. It's associated with MENs type 2A and B. And the effects of the parafollicular cells, they form a C or an amyloid of calcitonin. And then lastly, there's anaplastic, which is the worst prognosis. It invades local organs, and it often presents as like a solid, woody feeling thyroid. All of these, the treatment is going to be thyroidectomy plus or minus iodine ablation. Moving over to the parathyroid glands, we've got a 69-year-old post-op from a total thyroidectomy who presents with numbness and tingling in the perioral in his fingers and toes. Upon tapping of the facial nerve, there's contraction, and when you went to inflate the blood pressure cuff, there were carpal spasms. So the diagnosis here is hypoparathyroidism. It predisposes in patients to prolonged QT because of the hypocalcemia. And then you want to treat with IV calcium gluconate and vitamin D supplementation. Next up, we've got a 55-year-old who presents with depression and fatigue. Over the past months, he's had recurrent kidney stones, muscle aches, constipation, and a broken arm. Labs show an elevated calcium and chloride, as well as hypophosphatemia. The diagnosis here would be hyperparathyroidism, and this is going to be high to normal PTH, and we want to treat this with surgical removal and then electrolyte corrections. We talked about hypercalcemia already. Treat with vigorous IV fluids and then loop diuretics. So he's got the classic bones, stones, and psychiatric overtones. Now we've got adrenal glands. So we've got a 57-year-old man who presents with purple striae on his abdomen. Over the past months, he's gained weight in his face and neck, and there's been worsening of his diabetes and weakness. On exam, he's hypertensive. So this is a classic Cushing's syndrome. The next best step would be a low-dose dexamethasone suppression test. And then if that is positive, you want to follow up with a high-dose dexamethasone suppression test. And you can do ACTH to help localize whether this is going to be Cushing's disease or from the pituitary, or Cushing's syndrome from ectopic ACTH or an adenoma. So we treat with surgical resection of the adrenal or pituitary adenomas or treating the underlying cancer. So a 38-year-old woman is found to be hypertensive at a health fair screening and confirmed with her PCP. After starting HCTZ, she experiences horrible cramping. Lab studies show hypernatremia, hypokalemia, and metabolic alkalemia. So this is a contraction alkalosis, and this is due to Conn syndrome or hyperaldosteronism. The aldosterone is forcing her to keep as much sodium as possible at the expense of potassium and bicarb. And you can screen for this with an aldo-renin ratio. and you want to confirm with a SALT test. So treat with surgical resection if there's an adenoma, or spironolactone if there's hyperplasia or bilateral adenomas. So now we've got a 43-year-old woman who presents for follow-up for panic attacks. She's had intense palpitations, headaches, and sweating, and a feeling of doom. And then her blood pressure on exam today was 210/145. So this can be a presentation of a pheochromocytoma. You want to screen for these with urine metanephrines, the VMA and HVA, and you can localize this with a scintigraphy. So we can treat these with surgical resection if you can find them, and follow up with alpha blockades and phenoxybenzamine. So they're the rules of 10, where 10% of these are going to be familial, 10% bilateral, 10% located outside the adrenal medulla, and so on. So next up, we've got a 23-year-old man with a history of hypothyroidism, and he presents with abdominal pain, nausea, vomiting, and weakness. On exam, he's hypotensive, and he appears very tan, especially within the skin folds and palms. Labs show hyperkalemia and hyponatremia, so sort of the opposite of the Conn syndrome. And this is going to be Addison's disease. And the next step would be screen with cortisol and ACTH. You can confirm this with an ACTH stimulation test if the adrenals are not able to respond. And you can treat this with glucocorticoids and fluticortisone. So this is commonly what's known as JFK's disease. This is why he was so tan and golden. And this is worrisome because it's related to a lot of other autoimmune diseases in the United States. But abroad, TB is actually the most common cause of Addison's. Working our way into diabetes, we've got a 57-year-old African-American man presenting to his PCP to establish care. He's overweight and sedentary, and a screening CMP shows a fasting glucose of 138. The next best step here is to recheck a fasting glucose, and alternatively, you can get a hemoglobin A1C or do a 75-gram glucose challenge. So you would need to have 2 fasting glucose levels that are elevated, A1C above 6.5, or failing a glucose challenge test to diagnose diabetes. You want to treat this with a diet rich in fiber and low in sugars, and exercise with a goal of weight loss. So some of the common drugs that you can use to supplement this, metformin is recommended as a first-line therapy in almost everyone. It enhances liver insulin sensitivity, and it causes weight loss. The most common side effect is GI effects, and you have to stop using this in chronic kidney disease due to the risk of lactic acidosis. Next up are GLP-1 agonists. They all end in tides, and they augment insulin and reduce glucagon. There's less risk of hypoglycemia with these agents, and new studies are showing a cardiovascular benefit. Next up, they have the SGLT2 inhibitors. They end in flozins, and these increase the release of blood glucose in the urine. They block the urine reuptake inhibitor, and they can cause euglycemic DKA, which is a complication. And then both of these, like I said, were found to decrease the risk of MI and stroke in the leaders and the outcome trials. Now, some of the older medications, sulfonylureas, they end in rides or zides. They stimulate the pancreas to produce more insulin, and you have to watch for hypoglycemic events, and there are also sulfa drugs, so you have to watch for sulfonylurea allergies. Lastly, there's thiaglitazones. They end in glitazone. They reduce insulin resistance in the body, but they can cause weight gain and are contraindicated in CHF. And then if none of these medications work, or your hemoglobin A1C is above 9, it would be time to initiate insulin therapy. It's self-administered sub-Q, and it's the gold standard is a basal bolus. Oftentimes 70-30 and sliding scale are used for convenience. Some of the complications of diabetes. Say we have the patient from the last vignette begins taking metformin and sulfonylurea. While at church he begins to feel faint, sweaty, and shivering. He admits to forgetting to eat breakfast. So diagnosis here would be hypoglycemia. So this can be cause of syncope, falls, and comorbidities in diabetes. You want to treat with sugar or glucagon injections. And then over the following 15 years, some of the long-term complications of diabetes. He develops numbness in his extremities and blurred vision. On exam, there's a quarter-sized ulcer found in his foot, and laboratory studies show a rise in creatinine. So these are going to be microvascular complications like neuropathy. It's commonly stocking and glove. It affects the long nerves first. It can lead to neuropathic pain, and you can also get ulcers due to the lack of sensitivity. You can treat with gabapentin, TCAs, or pregabalin. Next up is retinopathy. You want to screen annually with an ophthalmologic exam, and you want to prevent with good blood pressure and glucose control. Lastly, there's some ulcers and Charcot joints. Repetitive injuries go unnoticed, and infections are prevalent in diabetes due to the immunosuppression. And since they're not able to feel their feet as much, these injuries can go unreported and get a lot worse. And then the nephropathy, you can screen with microalbuminemia. You want to treat with an ACE inhibitor or an ARB. Now, hyperglycemic events to look for. So we've got a 20-year-old with a history of diabetes type 1 who presents to the ED obtunded. On exam, he's hypotensive with rapid, deep breaths or Kussmaul's breathings. And he has a faint, fruity odor. His friends noticed him drinking and peeing a lot the past few days, and they never knew that he was a diabetic. Labs show glucose of 671, sodium of 153, that's a pseudo-hypernatremia, and a potassium of 3.1, chloride of 108, and a bicarb of 12. So here we've got a large gap, and this is a diabetic ketoacidosis. Diagnosis requires ketonemia and acidemia. So the next best step here would be 2 large bore IVs, rapid saline infusion, and then you want to start an insulin drip. Eventually you're going to have to add potassium into those as well. And you want to monitor for cerebral edema and respiratory depression with frequent neurologic checks. Next up, we've got a 76-year-old woman who's found down in her home. She fell in the kitchen 2 days ago and fractured her hip, and she's been unable to call for help. She's confused and disoriented on exam, and you do a blood glucose test, and it's over 900. So this is hyperosmolar hyperglycemic non-ketotic syndrome, or HHS, and you want to check serum osmolalities here. You can treat this with 2 large bore IVs and rapid saline infusion, and then you want to move to half normal saline and an insulin drip. So finishing up with pancreatic islet cell tumors, we've got a 34-year-old who presents with intermittent palpitations, diaphoresis, tremors, and syncope. Her labs show a glucose of 53. So this person is presenting with hypoglycemic symptoms, and they are not diabetic. So we can see this as either surreptitious use of insulin, or if there is a positive C-peptide, you can look at insulinomas. So you can confirm this with an elevated insulin and C-peptide on fasting. So now we've got a healthy 45-year-old who presents with a necrotic rash in the upper thighs. He was recently diagnosed with type 2 diabetes despite living a healthy lifestyle. So this is indicative of a glucagonoma. You can confirm this with low amino acid levels and high glucagon. So this migratory rash is pathognomonic for glucagonoma, and then the fact that he's a healthy individual, it does not seem like MODY or mature onset diabetes of youth. Lastly, we've got a 53-year-old man with recurrent abdominal pain and GI bleeds, despite being on BID omeprazole and H2 blockers. EGD shows ulcers in the distal duodenum, and gastrin levels are elevated. So this is Zollinger-Ellis syndrome. This is confirmed with a secretin stimulation test, and you can find a tumor with the somatostatin receptor scintigraphy. So these are going to be like extreme GERD, out of proportion with a normal presentation. And then we've got a 61-year-old with recurrent loose stools, hypokalemia, and maldigestion. A CT scan shows a pancreatic mass. So this is a VIP-oma, or Werner Morrison syndrome. It's going to be a wet secretory diarrhea. So one more thing to consider is multiple endocrine neoplasias. So each of these have a common sort of spectrum of disease that they go through. So MEN1 has pituitary adenomas, facial angiofibromas, parathyroid tumors, and then some of these pancreatic islet cell tumors that we just discovered. Next up is the MEN2As and 2Bs. So these have both medullary thyroid cancer. MEN2A has hyperparathyroidism and pheochromocytomas. And then MEN type 2 has Marfanoid syndrome or Marfanoid habitus. They have mucosal neuromas, and they have pheochromocytomas. So starting out for hematology and oncology, some of the learning objectives are to discriminate the cause and management of microcytic, macrocytic, and normocytic anemias, to identify inherited hemoglobinopathies, to interpret the cause or the common causes of coagulation disorders and determine anticoagulant management, to differentiate the subtypes of leukemia and lymphoma, and to classify the common transfusion reactions and their management, and then underlying identify some pathologies from the blood smears. So starting out with anemias, we've got a case of a 23-year-old woman who presents to her PCP with headache and fatigue. She's also noticed decreased exercise tolerance and cravings for ice and dirt. She has had irregular heavy menstruation since menarche at age 13, and she eats a vegan diet. Vital signs show a blood pressure of 109/72, a pulse of 96, and on exam there's conjunctival pallor. The next best step here would be to do a CBC to determine if she's anemic, and you can order a reticulocyte count and a blood smear for further workup. Anemia can be confirmed with the low hematocrit and hemoglobin, and further subdivided by their MCV, the size, and reticulocyte count for a clearer differential diagnosis. MCVs less than 80 is considered microcytic, MCVs greater than 100 is considered macrocytic, and MCVs between 80 and 100 is normal or normocytic, and the treatment depends on the specific subtype. The transfusion is limited to those with hemoglobins less than 7, or if they require increased oxygen carrying capacity, like if they have CAD, we might increase that to 8 or 9. So looking at microcytic anemias first, we've got an 18-year-old mother at 20-week gestation who presents with pallor, fatigue, and lightheadedness. She has a history of menorrhea and restless leg syndrome. Hemoglobin is 9.1 and MCV is 96, and a smear shows hypochromic microcytic anemia. So this is iron deficiency anemia. It's the most common hypochromic microcytic anemia. And the first steps to order are going to be iron studies, so ferritin, iron, and total iron binding capacity. And it's caused by nutrient deficiencies or increased requirements. For instance, as a pregnant mother, toddlers, and adolescents when they're growing large amounts. It can also be caused by chronic loss of GI bleeds or menstruation, and it can be treated with oral iron supplementation like ferrous sulfate. A lot of people don't tolerate this as well. It causes a lot of GI upset and constipation. So you can try parental iron like iron dextran. And it's also associated with restless leg syndrome. So if you have someone with restless leg, consider checking an iron study on them. Next up, there's a 30-year-old African-American man who presents to his PCP for routine screening. He has a family history of anemia. His hemoglobin is 12.8, and his MCV is 67, and RDW is 13. The smear shows hypochromic microcytic anemia, and there are target cells. So this is an alpha thalassemia minor. There's not often a lot of symptoms, but they can have a family history of thalassemias. His hemoglobin is mildly reduced, and his MCV is extremely small, but his RDW, or the amount of difference between all of these red blood cells, is normal. So they are all very small, and that's by design because the alpha thalassemia trait. And it's usually asymptomatic, and it doesn't require treatment. Next up, we've got a 58-year-old immigrant who's being treated for latent TB, and he develops fatigue and numbness in her fingertips. Hemoglobin is 10.8 and MCV is 73. Iron studies show an increased iron ferritin with a normal total iron binding capacity. So this is more of a sideroblastic anemia, especially being treated for latent TB. Isoniazid, if you're not adding vitamin B6, can cause this. And you can confirm it with bone marrow biopsies showing ringed sideroblast. You can treat by removing the offending agent or adding B6. So chloramphenicol, isoniazid, alcohol, or lead poisoning can all cause this. So thinking about macrocytic anemias now, we've got a 33-year-old activist who presents with increased clumsiness. She finds herself catching her feet and tripping on objects. She's also had a sore, swollen tongue. She's been a strict vegan for the last 8 years, and on exam there is decreased vibratory and proprioception up to the ankles bilaterally. Her hemoglobin is 10.1 and MCV is 113. She's got a megaloblastic anemia with hypersegmented neutrophils on her smear. Her diagnosis here would be a B12 deficiency. The next steps is you can order a B12 level, and with all your macrocytic anemias, you want to order a methylaminic acid and homocysteine levels. It's caused by pernicious anemia, alcoholism, vegetarianism or diets that are low in B12, Crohn's disease, and you can also have a tapeworm infection. You can treat this with B12 replacement or intrinsic factor replacement if you have pernicious anemia. So next we've got a 67-year-old widower who presents with fatigue and shortness of breath. On exam, there's considerable pallor. Her hemoglobin is 9.6 and MCV is 110. She's got a megaloblastic hypochromic anemia seen on her smear. The diagnosis here would be folate deficiency, often from a tea and toast diet, so diets low in folate. Next steps would be ordering a folate level, B12, and serum methylmalonic and homocysteine levels. It's caused by the tea and toast diet, alcoholism, long-term antibiotic use, because we get a lot of our B12 converted from the bacteria in our gut, and pregnancy, and drugs like methotrexate and anticonvulsants lower folate. You can treat this with folate or B9 supplementation. Going into the normocytic anemias, we've got a 49-year-old woman with RA and CAD who presents with increasing fatigue. She has chronic disease course. Her hemoglobin is 9.8, MCV is 81, and her peripheral smear shows a normochromic microcytic anemia. So this can be the anemia of chronic disease. Next best step would be iron studies to differentiate this with iron deficiency anemia. This is going to have a high ferritin as opposed to low ferritin. And we want to treat by correcting the underlying inflammation and allowing the body to utilize the iron stores that it has. Next up, there's a 67-year-old diabetic woman on dialysis presenting with tiredness and lightheadedness. She was diagnosed with diabetes 15 years ago, and she's been on dialysis for 3 years, consistently attending their sessions. Hemoglobin is 10.1, MCV is 85, and RDW is 11. Peripheral smear shows a normochromic normocytic anemia. The diagnosis here would be EPO efficiency from the chronic kidney disease. The next steps would be iron studies to differentiate this between anemia of chronic disease and iron deficiency anemia. And the treatment would be erythropoietin replacement therapies with her dialysis. So last, we've got a 24-year-old school teacher who presents with fatigue and bruising following a viral illness. She's had fever and rash on her face 2 weeks ago, and on exam there are petechia and ecchymoses on the extremities as well as pallor. Her hemoglobin is 7.1, WBCs are 0.9, and platelets are 12,000. The diagnosis here would be aplastic anemia, and you can do a bone marrow biopsy. The treatment would be a bone marrow transplant and judicious transfusions. Some of the causes here are radiation, medications like chloramphenicol, sulfonamides, gold, and carbamazepine, or viral infections. This is likely a parvovirus B19 infection, and chemicals like benzene or insecticides. So going to the hemolytic anemias, we've got a 35-year-old woman with SLE who presents with shortness of breath and dark urine. On exam, there's scleral icterus and her spleen tip is palpated. Hemoglobin is 6.7 and MCV is 93. Reticulocyte count is elevated and schistocytes are seen on blood smear. The next best test would be a Coombs test here. We want to look for elevated LDH, elevated bilirubin, and elevated reticulocyte counts. And haptoglobin is going to decrease. This is what's going to bind to all the extra hemoglobin after the red blood cells are lysed. Some common causes of intravascular hemolysis are immune hemolysis with cold agglutinins, mechanical trauma, microangiopathic hemolytic anemia like DIC and TTP, some drugs, paroxysmal nocturnal hemoglobinuria, and burns. Some of the causes of extravascular hemolysis are thalassemias, sickle cell disease, RBC enzyme defects like G6PD deficiency and pyruvate kinase deficiency, immune hemolysis from warm agglutinins, and RBC membrane defects like hereditary spherocytosis. And with all of these, we want to treat the underlying cause and transfuse only when necessary. So sickle cell disease, we've got a 4-year-old African-American girl who presents with painful hands and legs. On exam, there is scleral icterus and a palpable spleen tip, and painful swollen dorsums of her hands. Hemoglobin is 8.2, MCV is 87, and RDW is 24. Peripheral smear shows sickling cells. The next best step to confirm here would be a hemoglobin electrophoresis, and this is an autosomal recessive condition common among African and Middle Eastern descent due to the heterozygote advantage of malaria. So those that carry the trait of sickle cell disease are actually of less risk of malaria infections. Some of the complications include acute chest syndrome, which is very deadly, and you need to screen for anyone with chest pain and sickle cell disease. Splenic infarcts, which will lead to a lot of pathologies. Avascular necrosis, especially of the hip. priapism, CVAs and blindness, abdominal crises, renal papillary necrosis, aplastic anemia, leg ulcers, and there's an increased risk of salmonella osteoarthritis. So you want to treat the crises with IV fluids, morphine, and then warming and oxygen to make sure they're in the correct environment for that. The long-term prevention is proven to be effective with hydroxyurea. It will increase the fetal hemoglobin. This is even shown true in places where there's low nutrient density in the foods. Even in sub-Saharan Africa, where some of the children are malnourished, hydroxyurea still decreases the amount of crises that they face. Secondary prevention of morbidity is usually accomplished with penicillin prophylaxis for anyone under 6 years old. You want to prevent staph or strep infections like strep pneumonia, sepsis, and salmonella osteoarthritis. Vaccines against any encapsulated organisms from the splenic autoinfarcts, and then folate administration, hydration, and temperature control to decrease their risk of anemia in a sickling crisis. Other inherited hemolytic anemias, we've got a 29-year-old woman with a personal and family history of anemia, and she presents on an outpatient elective cholecystectomy. Upon pathologic review, there are multiple pigmented black stones, or hemoglobin stones, and she's got a hemoglobin of 12.6, MCV of 81, and RDW of 12. Her smear shows spherocytes. They're very round. They don't have the biconcave shape. So the diagnosis here would be hereditary spherocytosis. You can confirm it with an osmotic fragility test, and you want to treat any symptomatic patients with a splenectomy, and they'll oftentimes need a cholecystectomy for pigmented gallstones as well. Now there's an 18-year-old African-American man, and he develops jaundice and dark urine after taking a malarial prophylaxis for a study abroad trip. Peripheral smear shows bite cells and Heinz bodies, or little blue inclusions within the RBCs. The diagnosis would be G6PD deficiency. You can confirm with a G6PD level, and the treatment would be avoiding sulfur-containing antibiotics, antimalarials, or even favabines for those with high G6PD deficiency. So last, we've got a 35-year-old man who presents with abdominal, back, and muscle pain. He has a long history of dark urine upon awakening, but attributes it to dehydration. A smear shows a normochromic normocytic anemia, so this can be the case with paroxysmal nocturnal hemoglobinuria. You can confirm it with flow cytometry for CD55 and CD59. Old tests that you could do are the sugar water test or the HAM test, which try and show lysis under conditions of increased acid or osmotic stress, and you can treat this with steroids or bone marrow transplant. So ITP and TTP. So a 31-year-old woman presents with ecchymoses on the skin despite no recollection of trauma. She has had increasingly heavy periods and bleeding of her gums when brushing her teeth. On exam, there are petechia and purpura and ecchymoses, and there's no splenomegaly. Platelet count is 12,000. The diagnosis would be immune or idiopathic thrombocytopenic purpura. You can treat with steroids, IVIG, or a splenectomy if it's severe. Next, there's a 45-year-old African-American woman who presents with fevers and an altered mental status. On exam, petechia are seen. CBC shows WBC count of 7.3, hemoglobin of 8.2, and platelets of 23,000. Peripheral smear shows schistocytes. So this is a thrombotic thrombocytopenic purpura. They lack ADAMS TS13, the protease, and they cannot cleave von Willebrand factor. So this leads to lysing of their red blood cells in the periphery. You can treat this with plasmapheresis, steroids, and a splenectomy. And the classic presentation is similar to HUS with the addition of fever and altered mental status. So now blood infections. We've got a 22-year-old college student returning from a study abroad trip to India where he developed waxing and waning fevers, chills, and myalgias. So this is most likely malaria. The next best step is a peripheral smear with Giemsa stain, looking for the organisms within the red blood cells. So your Plasmodium falciparum is the most resistant and aggressive. It's got an increased risk of cerebral edema, especially in young children who are infected with it. Next, there's P. ovale and Vivax. So these have a 48-hour cycle, and they also form hypnozoites that can lay dormant in the liver. Next is P. malariae, one of the oldest ones considered. This has got a 72-hour cycle, And with all of these, you can try and treat with quinine or tetracycline, mefloquine and atovaquone, proguanil, or IV quinidine and doxycycline. And for any of the infections that have hypnozoites, you want to add primaquine to get the hypnozoites in the liver. So now we've got a 36-year-old hiker from Massachusetts who presents with flu-like illness consisting of chills, sweats, malaise, fatigue, and a headache. On exam, there is no rash. However, there is scleral icterus and a palpable spleen. So this is babebiosis. The next best step here would be a peripheral smear with Gamza stain, looking for the organisms. And you can treat this with atovaquone azithromycin or quinine clindamycin. Moving into platelet disorders, there's a 63-year-old woman who's post-op day 4 from hip replacement, where she's developed calf pain and redness. She's been receiving prophylactic low molecular weight heparin. Lab studies show a platelet count of 134,000, and this is down from over 300,000 the day before. The diagnosis would be heparin-induced thrombocytopenia. It's caused by a heparin platelet factor 4 complex antibody, and you can screen with the antibody assay or serotonin release assay. You want to treat by stopping heparin immediately and starting a direct thrombin inhibitor like dabigatran, atragafan, or leuprolin. Next, we've got a 13-year-old African-American girl who presents with menageria and a history of bleeding gums. Her father has a history of excessive bleeding from cuts and bruises. Her PTT is mildly elevated, but PT and INR are both normal. So this is von Willebrand's disease. It's confirmed with a rhizocetin-induced platelet aggregation test, and you want to treat with desmopressin and factor VIII concentrates if needed. This is a very common autosomal dominant inherited disease. Next, we've got a 23-year-old man with increasing bruising and tenderness to bleed. Labs show normal coag studies and a prolonged bleeding times. So if the coagulation studies are normal, it's not part of that cascade. Bleeding times tend to predict more platelet disorders. The diagnosis here would be some type of platelet dysfunction, either Bernard-Soulier syndrome. It's associated with GB or G1B and low amounts of very large-sized platelets. Or you can think of Glanzmann's thrombocytopenia. It's associated with GP2B and 3A deficiencies. Moving into coagulation disorders, we've got a 16-year-old boy who presents with recurrent knee pain and swelling. Whenever he hits his knee, it swells up very large, and he's had a history of bleeding following dental procedures. On exam, his right knee has decreased range of motion and a large effusion. Coagulation studies show a prolonged PTT. So this is hemophilia. It's an X-linked condition with a deficiency of factor 8. Hemophilia B has a deficiency of factor 9. Either of these can be treated with desmopressin for mild disease or factor 8 or cryoprecipitate for severe disease. Next, there's a 35-year-old man in the ICU for sepsis following a motor vehicle accident, and he develops petechia and ecchymoses. On exam, there's blood oozing from surgical sites. Hemoglobin, platelets, and fibrinogen are all decreased, and PTT and PT are elevated. Smear shows schistocytes. So this is disseminated intravascular coagulation, DIC. It's caused by infections, amniotic fluid emboli, trauma, malignancies, and snake venom. You can treat this with supportive measures and FFP. Try not to give too much extra blood and platelets because they'll continue to lyse. Next, we've got a 54-year-old alcoholic with a history of celiac disease who presents with scalp laceration. Appropriate cleaning and repair was performed, yet blood is still oozing through the dressing. Labs show a prolonged PT and PTT. So this is a vitamin K deficiency and liver disease. So vitamin K dependent factors are your 2, 7, 9, and 10. You can treat these with FFP and vitamin K supplementation. So celiac disease impairs a lot of your absorption of fat-soluble vitamins. And those with alcoholism have liver disease, which impairs the production of vitamin K. So both of these groups are at risk. Going into hypercoagulability and anticoagulation, we've got a 32-year-old woman being discharged from the hospital following her second DVT. She has a family history of stroke in her mother, and she and her husband have tried to conceive for 5 years and have had 3 miscarriages in that time. So this would be a hypercoagulable state, likely antiphospholipid syndrome. You can have antithrombin 3 deficiency, antiphospholipid syndrome, protein CNS deficiency, factor V Leiden disease, or homocystinuria. All of these will increase your risk of a hypercoagulable event, and they need lifelong anticoagulation. Some of the anticoagulants to think about are heparin or low molecular weight heparin, and it's given IV or IM to stabilize antithrombin 3 within the body. You want to monitor the PTT, and you can try to reverse these agents with protamine sulfate. Low molecular weight is used more in those with kidney disease because of heparin's long excretion time. So warfarin is an oral vitamin K antagonist. You want to monitor the INR, and it's a CYP450 metabolite, and it's very teratogenic, so you need to watch it in those with pregnancies. You can try a DOAC, or a direct oral anticoagulant. A lot of them attack factor 10A and 2, and they give orally, and they all have reversal agents approved for them now. There's more stability than warfarin, which can be affected with how much vitamin K the individual takes in, and other digestive properties. Lastly, there is aspirin and clopidogrel. These aren't anticoagulants, these are antiplatelet agents, and they're important in prevention of stroke and CAD. Moving into the white blood cells for plasma cells, there's a 78-year-old African-American man who presents with an arm deformity after bumping into a door. He's had 3 hospitalizations in the past year due to recurrent pneumonia, where they discovered his kidneys were failing. They showed hypercalcemia with decreased anion gap and anemia. Imaging studies showed a fractured humerus and lytic bone lesions. So this is multiple myeloma. You can screen with a serum and urine protein electrophoresis, SPEP and UPEP. And you want to confirm with a bone marrow biopsy showing greater than 20% plasma cells. You can treat with a cell transplant in younger healthy patients, or alkylating chemotherapy and radiation in older patients. So this is related to MGUS, or monoclonal gammopathy of unknown significance. Up to 1 in 20 of people with MGUS are thought to present with multiple myeloma per year, so it's an important screening procedure. And he has the classic CRAB symptoms of kidney disease, anion gap and anemia, hypercalcemia, and bone lesions. Next, we've got a 65-year-old who presents with increasing fatigue and weight loss. On exam, there's diffuse lymphadenopathy and decreased sensation in the hands and legs. Bilaterally, labs show an AKI and IgM elevation. So this is Waldenstrom's macroglobulinemia. Anything with IgM greater than 5 grams per deciliter. Complications occur due to hyperviscosity syndrome, so think the peripheral neuropathy, and you want to treat with chemo or plasmapheresis. So for myeloproliferative disorders, we've got a 58-year-old man who presents with increasing headaches, dizziness, weakness, and visual impairment. He mentions that he's very itchy after taking a shower, and over the past week he's had 2 bloody noses without incident. He denies working in an underground parking garage or smoking. Labs show an elevated RBC, hemoglobin, and platelet. So this is a polycythemia vera. It's related to a JAK2 tyrosine kinase mutation. It's a gain of function. And you want to rule out that he's got any form of carbon monoxide poisoning, like working in a parking garage or smoking, that would increase his baseline hemoglobin. And you can treat this with phlebotomy. Next, there's a 46-year-old woman presenting with burning pain and redness in her extremities. On exam, her spleen is palpated. Labs show platelet count of 825,000. This is essential thrombocytosis. You want to rule out any causes of secondary thrombocytosis like infection, inflammation, or bleeding. And you want to treat with anagrelide or aspirin to prevent strokes. Last, we've got an 81-year-old man who presents for routine screening to his PCP. CBC shows pancytopenia, and peripheral smear shows tear drip cells and Howell-Jolly bodies. The diagnosis would be myelodysplastic syndrome or myelofibrosis. Next step would be a bone marrow biopsy, and they can get a dry tap, which would show cartilaginous fibrosis with absent hemopoietic cells, and you want to treat this with transfusions. Going into the leukemias, there's a 5-year-old who presents with increased fatigue and bone pain. In the past 2 months, she's been sick 3 times. On exam, the child appears pale with petechiae and a palpable spleen. Liver shows WBCs of over 100,000 with increased lymphoblasts. This would be an acute lymphocytic leukemia. It's more common in those 5 years or less, increased risk in those with Down syndrome. You want to confirm this with a bone marrow biopsy, and you want to treat with aggressive chemotherapy. Next, there's a 46-year-old man who presents with gum bleeding, epistaxis, and petechiae. Labs show WBCs of 78,000 with many myelocytes and promyelocytes. The smear shows many blast forms with cytoplastic crystals, or Auer rods. The diagnosis would be an acute myeloid leukemia. You can diagnose this with bone marrow biopsy, and you want to treat with a bone marrow transplant. This is more common in middle-aged, like 30s to 50s. Next up, there's a 54-year-old who presents to a PCP for routine screening. Review of systems was positive for fevers and night sweats, or B symptoms. Labs showed WBCs of 128,000 with increased eosinophils and basophils. Decreased leukocyte alkaline phosphatase, so this is not a leukemoid reaction. The diagnosis would be a chronic myeloid leukemia. You can confirm it with bone marrow biopsy, and you want to look for a translocation of 921, the BCR and the ABL1 genes, and this is a Philadelphia chromosome. You can treat with imatinib or Gleevec and some of the other tyrosine kinase inhibitors. Last, we've got a 73-year-old who presents to his PCP for routine health screening. On exam, there's multiple small, firm, non-tender lymphadenopathy, and the patient's spleen is palpable. Labs show WBCs of 55,000 with lymphocytic predominance, and the smear shows smudge or ghost cells and many mature lymphocytes. This would be a chronic lymphocytic leukemia, and you can confirm with flow cytometry or bone marrow biopsy. You want to treat any symptomatic individuals with fludarabine, cyclophosphamide, and rituximab. And if your bone marrow biopsy came back for a dry stain with tartaric resistant acid phosphatase, or TRAP, you can diagnose hairy cell leukemia. Going into the lymphomas, there's a 26-year-old woman who presents due to night sweats, weight loss, and fevers. On exam, there's multiple 1 to 2 centimeter rubbery non-tender lymph nodes in the left cervical and supraclavicular area. Lymph node biopsy shows Reed-Sternberg cells, or 2 owl-eyed cells. The diagnosis would be a Hodgkin's lymphoma. The next best step is a staging CT of the abdomen, pelvis, and chest, and you can look at bone marrow biopsies. Staging using the Ann Arbor criteria, and you want to treat with radiation or chemotherapy. Next, there's a 55-year-old who presents with a painless peripheral lymphadenopathy for 6 months. He denies any B symptoms. Biopsy shows diffuse hyperplasia without tangible body macrophages, and there's a translocation of 1418. This would be a follicular lymphoma. You can treat this with radiation and rituximab. Next, there's an 8-year-old African boy who presents with a jaw mass. Biopsy shows starry stain appearance, or every once in a while you'll see an apoptotic region with a translocation in 8 and 14. This is a Burkitt's lymphoma. It's associated with EBV. Commonly in Western worlds, like the Americas, you can present with an abdominal mass, and you want to treat these aggressively with chemotherapy. For non-Hodgkin's lymphomas, a 62-year-old presents with increasing abdominal pain and weight loss. CT shows 10 centimeter retroperitoneal mass. Biopsy shows high-grade B cells in sheets. So this is a diffuse B-cell lymphoma, and you want to treat it with CHOP chemotherapy regimen. Next, there's a 12 hours after the first chemotherapy session. He experiences oliguria and intense toe pain. Labs show hypokalemia, hypocalcemia, hyperphosphatemia, and hyperuremia. The diagnosis would be tumor lysis syndrome. This is going to be usually when you initiate chemotherapy in large burden diseases, and you want to treat with aggressive IV fluids, rasburicase, and hemodialysis. Next, there's a 70-year-old man who presents with erythroderma. What began as a skin rash in his bathing suit region has covered his whole body in an itchy plaque, as well as lymphadenopathy. Peripheral smear shows cribiform or brain-looking T lymphocytes. The diagnosis would be Sézary syndrome. It can start as MF, mycoides fungoides, as like a fungus-looking rash in the bathing suit region, and you want to treat with chemoradiation. Moving into transfusion reactions, if there's a 23-year-old symptomatic anemia patient given a transfusion of packed red blood cells, 2 hours following the transfusion, he gets fevers and chills, but the lungs are clear to auscultation. This would be a febrile non-hemolytic reaction, so it's 2 hours later, he's febrile, but it's not reacting. Due to cytokine accumulation in the blood storage, you can treat this with Tylenol. And next, we've got a 37-year-old woman with a history of celiac disease receiving a blood transfusion following an MBA. Within a minute, she is tachypnic and in shock. This can be an anaphylactic reaction due to IgA deficiency. It's more common in people with celiac disease. You want to treat this with epinephrine and antihistamines. Next, there's a 45-year-old who receives a transfusion following a chemotherapy session. 6 hours later, she's in respiratory distress. And on exam, there's bibasilar crackles. This can be a transfusion-related acute lung injury, or TRALI, and this is due to donor anti-leukocyte antibodies. Next, there's an 18-year-old boy with beta thalassemia who presents with a rash, flushing, and pruritus 2 to 3 hours after his transfusion. And this is an urticarial transfusion reaction, and this is due to recipient IgE antibodies and mast cell activation. And you can treat this with antihistamines. Lastly, there's a 26-year-old woman who receives a transfusion reaction following a C-section. She has fever, flank pain, and hemoglobinuria within 1 hour. The direct Coombs test is positive. This is an acute hemolytic reaction. This is due to ABO incompatibility, and this is a medical emergency. Looking at some blood smears, this is a microcytic anemia. You'll notice it's very pale. There's large openings within the red blood cells. You can't see the hemoglobin within them. Next, there's a megaloblastic anemia. So you can see larger red blood cells. They're almost the size of these white blood cells. And then a hypersegmented neutrophil. Next, there's sickle cell disease. So you can see the sickling platelets. And then schistocytes. So these look like the Portuguese man of war helmets. Spherocytes. So these are very circular, and you can't see the biconcave within the RBCs. Next are bite cells, where they look like little bites were taken out of the cells. Rouleau formation, or coin stacking formation, common in multiple myeloma. Next is a dacrocyte, or a teardrop cells. These are in myelofibrosis. There are hour rods appeared there, so small spindle-shaped orange rods. Next, there are ghost cells, or smudge cells. You can see they used to be lymphocytes there, and their cytoplasm is kind of opened up. And then looking at the lymph nodes, there's a Reed-Sternberg cell. They look like owl eyes. And then the starry sky architecture. So that ends the hematology. And next up, we've got neurology and rheumatology.
I am Professor Patrick.
Professor.
Dr. Professor Patrick.